Hello, everyone. My name is Angelina Polsinelli. I am a clinical neuropsychologist at the Indiana Alzheimer's Disease Research Center, and I'm going to be talking about neuropsychiatric symptoms in early and late onset Alzheimer's disease. So I have no conflicts of interest. Current work suggests that neuropsychiatric symptoms may be more prominent in early than late onset Alzheimer's disease, especially when considering affective symptoms. However, neuropsychiatric symptoms, including affective symptoms, tend to be higher in middle age compared to later life, even in those without a neurological disorder. So we examined whether neuropsychiatric symptoms were actually higher in early compared to late onset Alzheimer's disease after accounting for base rates of neuropsychiatric symptoms in non-AD age match groups. So we pulled NAC data from those with cognitive impairment presumed to be due to AD and those without cognitive impairment at any visit. These groups were both further divided based on their age into an early age category, so those under age 65, and a later age category, so those 65 and over. And of note, the sample was predominantly non-Latino, Latino white adults with relatively high education. So this was a cross-sectional study examining neuropsychiatric symptoms as measured by the Neuropsychiatric Inventory Questionnaire, or NPIQ. And this was done at first visit. And first visit was defined as either the first time in which someone from the AD group was diagnosed with cognitive impairment, or it was the baseline visit for the cognitively unimpaired group. So we then compared early onset, which is the darker bars, to late onset, which is the lighter bars here. And we see that individuals with early onset have a greater overall neuropsychiatric symptom burden across all NPI categories, except for delusions. And overall symptom severity was also higher in those with early onset AD. We then ran multiple logistic regression models for each NPI symptom to examine the association of each particular symptom with age of onset of AD, so either early or late. And in these models, we adjusted for aging effects by including our early and late cognitively unimpaired groups and adjusted for sex, education, and disease severity via the CDR sum of boxes score. So we focused on that interaction effect between age, either early or late, and diagnosis, either AD or cognitively unimpaired, to explore disease-specific differences in neuropsychiatric symptoms between early and late onset AD. And so what we saw was that actually it was only euphoria, nighttime behaviors, and eating behaviors that all showed an interaction effect. And if we look closer at that interaction effect, which are the data that are presented here, we see that it's only euphoria and eating behaviors that demonstrate higher symptom prevalence in early onset compared to late onset. So in conclusion, we found that almost all neuropsychiatric symptoms were higher in early than late onset AD. But once we adjusted for higher rates of neuropsychiatric symptoms in those under age 65, the only disease-specific differences were in euphoria and eating behaviors. And these findings suggest that care partners of individuals with early onset AD may be at increased risk for lower quality of life, given how prominent a role neuropsychiatric symptoms play in care partners' perception of burden and stress. So future directions include examining progression of neuropsychiatric symptoms in early and late onset AD, adjusting for these age effects. And we'll also look at whether certain neuropsychiatric symptoms predict conversion from MCI to dementia. Finally, given that we know that there are substantial differences in risk and presentation of AD in various racial, ethnic, and socioeconomic groups, it'll be extremely important to be looking at neuropsychiatric symptoms in more diverse samples. So with that, I just want to say thank you to my collaborators and my mentors who are listed here. Thank you to the whole Apostolova Lab. We're very lucky to have such a great team. And thank you also to our funding and data sources. Finally, thank you to NAC for inviting me to give this presentation today.
Hello, everyone. My name is Michael L. Yang, Assistant Professor of Neurology at Oregon Health and Science University. Today, I'll be talking about my project entitled Monitoring Apathy, Depression, and Anxiety Using Technology Evaluation, funded by Oregon Alzheimer's Disease Research Center. Here are the aims of the project. First is to establish objective and continuous digital biomarkers that characterize behavioral symptoms, including apathy, depression, and anxiety using technology. Second is to identify environmental factors that contribute to these behavioral symptoms. The inclusion criteria is people who are part of the Digital Technology Core or Architect Life Lab of ADRC or Orchestrate. They have to be at least 60 years old with no major comorbidity. The study can last up to 9 months. This table shows the participants enrolled so far. During the study, our participants' symptoms were assessed weekly through online questionnaire. The online questionnaire consists of 3 different subscales from well-validated scales. These are the behavioral sensors and environmental sensors used as part of the project and examples of measures collected. This shows the severity of the 3 symptoms by week. As one can see, there's a week-to-week variability for the severity of these symptoms. This is weekly steps versus severity of depression. The red line is the regression line at the sample level, and the shaded area is the 95% confidence interval. As one can see, people tend to take less steps when they are depressed. This is weekly toss and turns on the bed versus severity of anxiety. As one can see, people tend to move around more on the bed when they're anxious. Now, let's look at the association between the environment and the severity of the symptoms. As seen, worse air quality, which means high PM 2.5, is associated with more severe apathy. So I will continue with recruitment, data collection, and analysis for this project. I'll publish findings as a journal article, and this project provides preliminary data and experience for future R01 submission. Lastly, I want to thank my funding agency, my mentor and co-investigator, Jeff K. and Zach Beatty, and all my colleagues at Architect. Thank you, and you are welcome to email me with any questions.
Hi, my name is Molly Mather. I'm a neuropsych postdoc at the Meslin Center at Northwestern University. I'm going to present on part of my dissertation work, which focused on neural precursors of depressive symptoms in amnestic mild cognitive impairment. So we know neuropsychiatric symptoms are common in AMCI and can cause quite a few problems. They're associated with poor outcomes and are also associated with higher risk of progression to dementia. And yet we don't really understand, why they develop, why they worsen. And what I was hoping to sort of dig into a bit with this study is looking at whether we can identify neural correlates of depression in AMCI and determine whether these markers predict progression to dementia. So there were sort of 2 aspects of this. The first was to establish whether atrophy in certain key regions in the brain that support emotion function, whether atrophy in those regions might predict change in depressive symptoms over time. So both whether sort of concurrently those change in the neural regions and change in depressive symptoms were associated, but also whether change in neurostructures were then temporally, later predicting change in symptoms of depression. And then whether change in neural precursors or atrophy in those key regions would be associated with higher likelihood of progression of disease. So I used ADNI data for this sample and utilized participants that were either cognitively normal or AMCI at enrollment, and then had at least 2 MRI scans and at least 2 ratings of depressive symptoms to allow for longitudinal analyses. Because this data is inherently nested, I used multi-level longitudinal structural equation modeling to account for both within and between person variance. First, I looked at parallel process models, which allows you to look at to estimate slope of change in neural markers, and then also slope of change in neuropsychiatric symptoms, and then whether the association between those 2 slopes is significant. And what I found is that first, these variables do change over time. So there was increase in depressive symptoms and also atrophy in each of the key regions that we had looked at. And atrophy was moderated by group. So there was faster atrophy in the cognitively impaired than the cognitively normal group. There was not direct correlation between the slope of change in depressive symptoms and the slope of change in neuromarkers. And then looking at this a bit more temporally, I then ran lagged models. So what this allows us to do is determine whether a variable at time 1 predicts the other variable at time 2 and vice versa. And so we did find that lesser amygdala volume predicted greater depressive symptoms at the subsequent time point, but that the inverse was also significant. So it's perhaps a bit more complicated than just a unidirectional relationship. And then for aim 2, whether change in these neural markers is associated with greater likelihood of progression of disease. We found that indeed a more positive slope of depressive symptoms is associated with greater likelihood of progression, which is in keeping with the literature to date. And we also found that greater atrophy in each of those key regions was also associated with higher likelihood of progression to dementia. So these results give some evidence that decline is happening in neural structures that support emotion function, even in the very early stages of the Alzheimer's disease process. And that the rate of atrophy in emotion centers is associated with higher risk of progression of disease, even at very early stages. And so this may be, a useful prognostic marker going forward. And then there's some indication that decline in neural structures that support emotion function do predict increase in neuropsychiatric symptoms, but perhaps in a bit more complicated way than just this sort of direct prediction. And so going forward, I think it would be useful to test these hypotheses in a sample with a greater range of neuropsychiatric symptoms, and perhaps including mild dementia at baseline to allow for more variability. Also to determine whether neuropsychiatric symptoms more generally are associated with neurodegeneration and emotion centers, to better understand the role of amygdala atrophy in predicting depressive symptoms, or perhaps related to other neuropsychiatric symptoms as well. And then to think about how we operationalize affective dysregulation and how we can best pick up on that in patients even very early on, so we can best manage and intervene going forward. And thank you for your time.
Hello, everyone. My name is Andy Aschenbrenner. I'm an assistant professor in the Department of Neurology at Washington University, and I'm happy to talk to you today about cognitive variability in preclinical Alzheimer's disease. We started this research program with a simple assumption that cognition is variable. That is, if I measure someone's cognitive ability today, tomorrow, and next week, those scores will not perfectly align. The reason being you have variability in your stress, mood, motivation, and other factors that might contribute to how well you can perform on any given cognitive test on any given day. And so in this graph here, I just plotted some hypothetical data. If we captured cognitive ability on a generic cognitive score at different months, you have some people who might be relatively steady across that 2-year interval here, and some people who have these huge swings in cognitive performance from measurement to measurement. And our question was, is the degree of cognitive fluctuations that you have indicative of risk of preclinical Alzheimer's disease? So we conducted a couple of studies to answer this question. The first was with the NIGHT ADRC cohorts, the Ambulatory Research in Cognition, or ARC test, which is a smartphone-based cognitive testing platform that administers 3 very brief cognitive tests 4 times daily for 7 days. So we have up to 28 measurements of cognitive ability across a 7-day period. And so with our sample of approximately 280 people who are all clinically healthy at the time of assessment, you can see here on the graphs on the right that on each of the 3 cognitive tests, those who are at risk for Alzheimer's disease, conceptualized here as having an ApoE4 allele or positive ApoE status, they perform worse on each of the cognitive tests we administered. These tests are scaled such that a higher score is worse performance. But on at least 2 of the tests, the symbols test and the grids test, which measure working memory and attentional control, the individuals who are ApoE positive also have greater variability from measurement occasion to measurement occasion. So across different days, their scores vary up and down to a greater extent than those who are negative for the ApoE allele. This finding is particularly interesting because other studies that compare healthy younger adults to healthy older adults have shown that older adults are actually less variable than younger adults across different days. And this is typically attributed to greater stability in motivation or mood or stress response as you age. And so if we show that variability then increases as you develop clinical impairment, there must be some protective factor that's being lost as you become impaired. And so the aim of our second study was to identify what that factor might be. So we did a more community-based study where we recruited healthy younger adults, older adults, and those with impairment to do a baseline pre-test battery that consisted of a impairment screener, affect, mood, personality questionnaires, working memory, and attentional control. And then the next day, they started an intensive 21 daily sessions of this cognitive battery that consisted of shortened versions of each of these. And so we now have 21 measurements of personality, mood, fatigue, working memory, and attentional control. We ended up with 66 younger adults, 52 healthy older adults who had no impairment, and 37 who are mildly impaired based on a CDR rating of 0.5. So the first thing to point out, SART is a measure of attentional control. So we replicate and extend the previous findings, particularly with variability. So here you can see that the younger adults are more variable than the older adults, just replicating the Schmeideck study. But then again, as you start to have clinical impairment, you have significantly greater variability in attentional control across different days relative to older adults. So we aim to look at all the other factors we collected and see if there's variability in mood or personality that might explain these findings. And across all the variables we looked at, agreeableness popped out as the most promising. Agreeableness is a personality facet that measures the extent to which you enjoy helping or contributing to others and how much you care about them and assist others who are in need of your help. And what you can see here is panel A is plotting the mean of agreeableness across the 21 days of testing. You can see that the younger adults are overall less agreeable than the older adults, and they're also more variable. So on some days, they're just really agreeable, and other days they're not agreeable at all. And the older adults are much more stable from day to day in terms of agreeableness. At the same time, the individuals who are clinically impaired are more variable in agreeableness from day to day relative to the older adults. So they too have some days in which they're really agreeable and other days which they are not. So we see this might be an important behavioral characteristic that explains some amount of cognitive variability. So our next steps would be to test that assumption explicitly and see whether variability and agreeableness does indeed mediate variability in cognition. And we'd like to see if these findings extend to a more generalizable cohort. Those that we recruited were particularly interested in being in a research study, and hence were probably relatively high on agreeableness to begin with. So it would be good to have a more generalizable cohort to study. Thank you very much for your time, and I'll end by thanking all my mentors and collaborators and my funding from the NIA that supported this work. Thank you again.
Hi, I'm Andrea Weinstein. I'm at the University of Pittsburgh, and I'm a clinical neuropsychologist with an interest in better assessment and prediction of dementia development. And as a neuropsychologist, I'm aware of the limitations of traditional neuropsych testing. And as we all know, research in clinical practice has shifted focus to earlier and more sensitive detection of dementia. But traditional neuropsych tests were originally developed to detect impairment in the midst of disease states, whereas AD neuropathology begins several years prior to detection on these tests. And these tests really measure cognitive capacity at a single time point under carefully controlled conditions. So as such, there's a need for cognitive assessment that effectively captures very early dementia risk. And this is an exciting time to be a neuropsychologist because there's the development of ambulatory assessments of behavior that utilize smartphones. And this comes out of ecological momentary assessment, which was done a lot in health psychology. And these ambulatory measures utilize smartphones to assess current psychological states. And this can be done multiple times per day over several days. And these methods have been adapted to mobile cognitive tests, which are very brief cognitive assessments administered by smartphone, such as this one done for a verbal learning and memory measure. And early evidence shows moderate to strong correlations between mobile measures as shown here, and traditional measures such as the Hopkins Verbal Learning Test. And these ambulatory measures are now being used to assess people at risk for AD. This is work out of Jason Hassenstad's group at WashU, where they examined 113 older adults without dementia. And they found that participants performed worse on an ambulatory memory task in the evening as compared to the morning. But in particular, people who were AD biomarker positive had the lowest early memory performance. And this work really brings up the idea that our everyday cognitive ability varies and isn't stagnant. And we know that variability in cognition peaks in early childhood and also increases again later in life. So what is driving this variability? And there's likely several factors contributing to cognitive variability, including sleep, alertness, mood. But in addition, there's evidence to show that intra-individual variability of daily activities is related to intra-individual cognitive variability. And in particular, this study out of Oregon State found that on days where people engaged in more social activities, they subsequently performed better on cognitive measures. And this is really important because we know that loneliness is actually a risk factor for AD, and people with higher loneliness show greater tau deposition and amyloid burden. So I'm asking, can ambulatory methods capture risk and resiliency factors for AD? And this is the focus of my K23, where I'm first looking at the association between AD neuroimaging markers and cognitive variability on these ambulatory tests, and whether cognitive variability is predictive of cognitive decline. And in particular, I'm exploring how daily life psychosocial factors are related to cognitive performance. And I'm measuring these psychosocial factors using EMA, where I'm asking questions about mood, stress, energy, social activities, things of that sort. And I've piloted this work with funding from the PIT ADRC, where we ran 40 older adults in this mobile cognitive testing and EMA measure. We found this was feasible and well liked by everyone. And in particular, cognitive variability on measures of processing speed and memory was a sensitive measure of NIH toolbox cognition. So in summary, mobile cognitive measures of variability correlate with established cognitive measures, and my ongoing work is measuring the cognitive variability in relation to AD neuroimaging markers and patterns in daily life psychological factors and psychosocial activities. And these results will help inform interventions that target psychosocial resilience factors for dementia. So thank you to the NIA for funding my work, and the PIT ADRC, which has funded my pilot work and much of my ongoing work, as well as my mentors and collaborators.
Hello, my name is Elizabeth Rodas. I'm an assistant professor at the University of Kentucky Alzheimer's Disease Research Center and Sanders Brown Center on Aging. Thank you to the organizers of the meeting today. I'm excited to talk to you today about research exploring the onset of behaviors characteristic of autism spectrum disorder as a cluster of neuropsychiatric symptoms observed in Alzheimer's disease and AD-related dementias. I have the following disclosures. During clinical experiences as an occupational therapist, I recognized similarities in behaviors in neurodevelopmental disorders and neurodegenerative conditions. For example, individuals in both groups presented with stereotypic behaviors such as rocking, humming, not making eye contact, and impaired communication, among other behaviors. This led me to hypothesize that autism-like behaviors are present in individuals with Alzheimer's disease and related dementias. However, there was limited literature exploring this comparison. We identified 3 areas to explore. In our first study, we wanted to examine if autism-like behaviors were present in individuals with cognitive impairment. We assessed 142 surveys and found that individuals did present with autism-like behaviors. Individuals who presented with these behaviors had a clinically different trajectory than those who did not have these behaviors. Specifically, individuals with autism-like behaviors had significantly earlier age of cognitive impairment onset by 5 years. They also had advanced cognitive impairment at the time of survey completion. We also found that these behaviors were present in a variety of dementia types beyond frontotemporal lobe dementia, including Alzheimer's disease, dementia with Lewy bodies, mild cognitive impairment, and vascular impairment as well. In our second study, we assessed how these behaviors were related to cognitive impairment, as well as behavioral and psychiatric symptoms of dementia. We found that there was correlation between the Gilliam Autism Rating Scale and the Neuropsychiatric Inventory. In addition, the Gilliam Autism Rating Scale added 6% variance to the CDR sum of boxes, indicating that individuals with these autism-like behaviors had advanced cognitive impairment, in addition to the neuropsychiatric symptoms that they were already accounted for on the NPI. We were also able to stratify individuals who had high behavioral and psychiatric symptoms of dementia but didn't present with autism-like behaviors. We found that the means and standard deviations for the GARS, the Gilliam Autism Rating Scale, had a greater than 1 standard deviation higher than the high behavioral and psychiatric behavior group. In our third study, we assessed post-mortem analysis of individuals who were presenting with autism-like behaviors prior to death. We compared with case controls for a total of an N of 56. We found that individuals had an increased tau pathology in the frontal and temporal lobes compared to the controls. These photomicrographs show p-tau immunoreactive pathologic features in a person who died at the age of 72 years following new onset of autism-like behaviors in panels A and B, and someone who died at the age of 76 without such behaviors in panels C and D. The person with autism-like behaviors had substantially higher levels of tau burden in the frontal lobes compared to the case control. We have identified that there's multiple types of dementia beyond just FTD who present with autism-like behaviors. We've also found that autism-like behaviors are present in individuals with ADRD and are associated with a different clinical trajectory, including earlier age of onset and associated with advanced cognitive impairment. These individuals who presented with increased autism-like behaviors also had a different pathology in their brains at autopsy. Next steps include looking at intervention options. In my current K23, we're conducting a clinical trial to explore caregiver training using environmental inputs so we can regulate behaviors and associate similarities between autism and pediatric-based therapies and delivering them in individuals with Alzheimer's disease and related dementias. Thank you to the UK ADRC, participants and care partners, as well as the faculty and staff for supporting this work. And thank you again to the organizers of the meeting today.
Hello, I'm Dr. Jennifer Gatchell from the Massachusetts Alzheimer's Disease Research Center, and I'm very happy to present our study probing mechanisms of emerging depressive symptoms in older adults using plasma and multimodal neuroimaging biomarkers. So depressive symptoms in late life are prevalent in unimpaired older adults and also in dementia, and indeed they're among the earliest neuropsychiatric manifestations. There's even subclinical symptoms confer increased risk for further cognitive decline. And despite this clinical relevance, the neurobiological mechanisms underlying these symptoms are poorly understood. And a better understanding is really needed to identify individuals with greater risk for AD and to develop more effective AD prevention strategies. Mechanisms such as neurodegeneration and cerebrovascular injury have been postulated as potential mechanisms, and the objective of the current study was to examine these mechanisms in synergy with AD pathology, cortical amyloid, to determine whether or not these mechanisms synergize with AD pathology to underlie emerging depressive symptoms in preclinical AD. And importantly, we wanted to do this using both plasma and neuroimaging biomarkers. To do this, we drew on data from the Harvard Aging Brain Study, a longitudinal observational cohort study at our site, in which individuals are unimpaired with no or minimal depression at study entry. On average, they're followed for over 7 years, and the average age at study entry is 72, with the demographics shown at the right. Depressive symptoms, while they're low or non-existent at entry, do emerge over time in a significant number of the cohort, and they are assessed annually using the 30-item geriatric depression scale. At baseline, to probe neurodegeneration, plasma samples from this cohort were assayed for neurofilament light, or NFL, as well as a panel of cerebrovascular injury markers. Also, all participants underwent Pittsburgh compound B to derive a measure of cortical amyloid, and they underwent longitudinal MRI scans from which we derived slopes of atrophy, regional atrophy, and global white matter hyperintensities. And in linear models, we examined these biomarkers interacting with cortical amyloid and predicting GDS over time. So our primary results are shown here, in which we found that higher plasma measures of neurodegeneration, or NFL, as well as ICAM1, a marker of cerebrovascular injury, synergize with cortical amyloid to predict increasing GDS scores over time. The results for NFL are shown in the topmost panel, and those for ICAM1 are in the bottommost panel. These biomarkers are coded by in yellow, greater than blue, greater than purple. And you can appreciate that for NFL in the top panel, we see that this effect in increasing GDS is the greatest for those with lowest levels of cortical amyloid in the left column, versus we see an opposite pattern for ICAM1 in the bottom panel. When we looked at neuroimaging markers, we found that medial orbital frontal cortical thickness or atrophy was associated with increasing GDS over time. In conclusion, through this study, we found that cerebrovascular injury and regional neurodegeneration, importantly measured through either the periphery or central imaging methods, synergize with AD pathology or cortical amyloid to predict emergent neuropsychiatric symptoms or depressive symptoms in an unimpaired group of community-dwelling older adults. In future work, we're in the process of replicating this in diverse cohorts, and we've begun to do that for the NFL finding. And we're also probing related molecular pathways such as tauopathy. And importantly, this has the implication to allow us to predict cognitive behavioral trajectories using both inexpensive and minimally invasive means, and highlight potential avenues for AD prevention by examining neuropsychiatric symptoms. In conclusion, I'd like to thank MADRC and HABS participants, colleagues, and mentors. Thank you for the opportunity to present these findings.
Hi, my name is Emma Rhodes, and I am a neuropsychologist at the Frontotemporal Degeneration Center at the University of Pennsylvania. I'm going to be telling you a little bit about my research on digital monitoring to detect autonomic markers of early empathy loss in the behavioral variant of frontotemporal dementia. So what we tend to see in BVFTD is an early and prominent deficit emerge in social comportment. So this could be disinhibited behavior, impulsive behavior, but for a lot of folks, it is a prominent loss of empathy for others. This loss of empathy is a hallmark feature of BVFTD. It's really disturbing to families and loved ones of the patient, and it's linked to poorer functioning for the patient themselves. It is driven by atrophy in a distributed network of brain regions, most notably in the salience network, so typically the inferior cingulate and the anterior insula. There are no treatments for empathy loss at this time, and we don't even know of any modifiable mechanisms. And additionally, part of what makes this research difficult to conduct is that empathy loss is a really subjective symptom, and so it can be difficult to measure reliably and objectively. But recent research highlights some physiologic mechanisms, including autonomic arousal, that have been implicated in empathy loss in BVFTD. So when we talk about the autonomic nervous system, really what we're talking about are these two reciprocally inhibitive systems, the sympathetic and parasympathetic nervous systems. The sympathetic nervous system is typically associated with energy mobilization and our subjective experience of negative emotions. We measure this typically using things like skin conductance and pupillary response. Whereas parasympathetic nervous system tends to be associated with energy conservation and the subjective experience of positive emotions, as well as prosocial behavior. And we tend to measure this using cardiovascular measures like respiratory sinus arrhythmia and heart rate variability. There has been some really lovely work out of UCSF demonstrating that empathy loss is correlated with autonomic arousal abnormalities in BVFTD. So specifically, we find that patients with reduced sympathetic arousal in BVFTD, they tend to have a sort of diminished response or insensitivity to negative emotions and stimuli. We also see that reduced parasympathetic arousal in BVFTD is associated with less empathic concern, less agreeableness, and less prosocial behavior, in addition to more emotional blunting. However, this data was collected using traditional telemetry methods, which require hardwired EKG and skin conductance leads, which can be really sensitive to confounding motion effects, and they can be obtrusive when we're measuring patients during behavioral testing. So my study uses digital measurement of autonomic activity to try to investigate more dynamic shifts in autonomic activity and how they relate to empathy loss in BVFTD. So I'm using a specialized smartwatch that measures both branches of the autonomic nervous system and includes additional features like an accelerometer, gyroscope, and GPS to additionally account for motion and movement in our analyses. Importantly, this watch is unconstrained by wires and machinery. It's really unobtrusive, and it allows for more continuous and task-based assessments. So my study aims to test the feasibility of using a digital watch to capture autonomic markers of early empathy loss in BVFTD. And so for this study, we're bringing patients into the clinic and we are collecting a brief resting baseline condition in addition to a longer behavioral testing condition. And in both of these conditions, we're going to look at either summative or dynamic features of their autonomic signaling and relate them to their performance on multiple tasks of empathy, spanning from your traditional caregiver questionnaire all the way to a naturalistic behavioral task. And really what we're hoping to do here is improve early detection of empathy loss in BVFTD, advance our understanding of autonomic mechanisms of empathy loss, and maybe even identify a novel intervention target for what's otherwise a really devastating and intractable neuropsychiatric symptom. Thank you to everyone involved at the ADRC for selecting me and nominating me for this video, and many thanks to the FTD Center, the Penn AI Tech Collaboratory who's funding this research, as well as the Memory Center and the Institute on Aging, and go Phillies.
Good afternoon. My name is Alex Jordan, and I'm an assistant professor at the University of Michigan. I will talk today about understanding the role of Alzheimer's disease pathology in mild behavioral impairment. Evidence suggests that later life neuropsychiatric symptoms may be a sign of Alzheimer's disease in at least some individuals. So a question is whether later life neuropsychiatric symptoms are associated with the presence of Alzheimer's disease biomarkers and with changes in brain function. To answer this question, we interrogated data from the Stimulation to Improve Memory study, which currently comprises about 100 well-characterized individuals across the dementia spectrum. We were able to leverage data from neuropsychological assessments, amyloid and PET scans, as well as the baseline MRI sessions. For the latter, we focused on the default mode network, which is known to be one of the brain's association networks that is primarily affected in Alzheimer's disease. We evaluated within and between network connectivity, as well as the ratio of these two measures, that is, network segregation. First, our results showed a trend for lower within default mode network connectivity for tau-positive individuals with a small effect size. However, there was significantly lower between default mode network connectivity for tau-positive individuals with a medium effect size, suggesting that the default mode network interacts less with other association networks for tau-positive individuals. Indeed, the default mode network was more segregated from the other association networks for tau-positive individuals, although this effect was only present at a trend level. Next, we looked at the presence and severity of the neuropsychiatric symptoms accounting for tau positivity. First, there were no significant effects of neuropsychiatric symptoms on connectivity within the default mode network. However, neuropsychiatric symptoms were associated with significantly less connectivity between the default mode network and the other association networks. And finally, neuropsychiatric symptoms were associated with significantly greater functional segregation of the default mode network from the other association networks. In conclusion, our results showed that less default mode network interaction is partially accounted by tau positivity. However, tau is not the only driver of these effects, as once we accounted for effects of tau positivity, neuropsychiatric symptoms still contributed to less default mode network interaction. Given the parent study, we excluded participants with moderate to severe neuropsychiatric symptoms. Although this limited our range of neuropsychiatric symptom severity, it was a good opportunity to consider early-stage symptoms as they relate to biomarkers. On that note, we focused only on dichotomous grouping of positive or negative biomarker status in brain's meta-regions. So a future direction is to index amyloid and tau burden at the nodal level to provide a more fine-grained understanding. Thank you for your attention. I would like to acknowledge our research program, support from the National Institute on Aging, and the Michigan Alzheimer's Disease Research Center.
Dear ADRC Spring Meeting participants, it's a great honor for me to present our work at this prestigious meeting. I'm Hülya Alugut. I'm a neurologist and a postdoctoral researcher at the University of California, San Francisco Memory and Aging Center. I will be sharing our research on the earliest psychiatric symptoms in patients with right anterior temporal lobe degeneration. The relationship between psychiatric symptoms and front temporal lobes is not a new concept and has been documented since the early 19th century. However, the underlying neural mechanisms of psychiatric symptoms in patients with frontotemporal dementia are not yet well understood. To address this gap, we focused on early-stage patients with varifocal atrophy through an international collaboration established in 2020. We included patients with FTD diagnosis, either behavioral or language variant, and predominant right anterior temporal lobe atrophy based on their initial neuroimaging. Our selection yielded 126 patients with a CDR score lower than 0.5 from 18 centers contributed case notes that we further coded to identify core symptoms. In line with the previous publications, memory, behavioral, and language problems were very common in our dataset. However, today, I'm going to zoom into the psychiatric features. Our analysis revealed 3 clusters of psychiatric symptoms such as obsessive-compulsive behavior, affective dysregulation, and somatization. Notably, preoccupations with food, puzzles, games, time and schedule were the most common domains observed in the obsessive-compulsive behavior cluster. I have to say that one of the strengths of this project is combining the qualitative and the quantitative data. The working group teased out each reported symptom to better interpret our results. Now, I would like to share some examples, and I would like to invite you to think whether those features are perfectly fitting any primary psychiatric diagnosis. Here are some examples for compulsive behavior. He gets easily aggressive if we don't follow his schedule. He can spend his entire time with puzzles, computer games, cycling, and writing religious quotes. She has a very interesting routine. Every Monday, she dresses up all blue and eats only pasta. Similarly, affective dysregulation was characterized by mood fluctuations, as seen in the examples. His reactions are very exaggerated, like a manic attack, but sometimes no reaction at all. And she got diagnosed with depression. She doesn't socialize much with friends anymore. Finally, somatization was observed in patients who displayed exaggerated reactions to tactile stimuli or reported body aches, pains, discomforts, and inner traveling feelings for which no etiology was found. Our study highlights the need for better designs to understand the role of right anterior temporal lobe in thought process, affect, and bodily sensations. Large sample size multi-center studies that perform consistent and prospective quantitative measurements of these core psychiatric symptoms are essential to further our understanding of this condition. I would like to extend my sincere appreciation to the huge team that contributed to this project, especially Professor Yolanda Pijnenburg, who is the co-PI of this project, as well as the Rankin Lab, the UCSF ADRC team, and other UCSF MEC members actively working on this topic. Thank you for your attention and for having me here today.
Hello, everyone. Today I will be presenting my work at the University of Kentucky, investigating the association between neurodegenerative pathologies and behavioral and psychological symptoms of dementia. So when we consider dementia, we most immediately think of memory impairment and global cognitive decline. However, dementia is often accompanied by many other behavioral and psychological symptoms. These symptoms include delusions, hallucinations, agitation, depression, anxiety, elation, apathy, disinhibition, irritability, night behavior disturbances, motor disturbances, and appetite disorders. These symptoms are operationalized on a 0 to 3 scale, with 0 being none, 1 being mild, 2 being moderate, and 3 being severe. On the right, you can see that patients with dementia suffer from much higher counts of co-occurring BPSDs compared to those that do not have dementia, with many patients with dementia suffering from 5, 6, 7, or more co-occurring BPSDs. Here we're interested in how several neurodegenerative pathologies are associated with these BPSDs. So here we're looking at 1, Alzheimer's pathology using Brock NFT staging, 2, late pathology using late NC staging, and 3, Lewy body pathology using the presence of neocortical Lewy bodies. We're specifically interested in how these neuropathologies are associated with BPSDs in individuals with early cognitive impairment. For this, we look only at individuals with a global CDR score of 0, 0.5, or 1, indicating that they are unimpaired or have mild dementia. So within this group, we look at 1, how severe Alzheimer's pathology or Braak stage greater than 4 is associated with BPSDs. 2, how the combination of Braak stage greater than 4 and neocortical Lewy bodies is associated with BPSDs. And finally, 3, how the combination of Braak stage greater than 4 and late stage greater than 1 is associated with BPSDs. So first, we're looking at the effect of severe Alzheimer's pathology, Braak stage greater than 4, and moderate or severe BPSDs. So this is a radar chart, which has a radial axis, which shows the percentage of moderate and severe BPSDs, that is 2 or 3 on the 0 to 3 scale, for each of the 9 BPSDs present here in individuals that have greater than 4 Braak or less than or equal to 4 Braak. And you can see here the individuals that have Braak stages greater than 4 have higher levels of moderate and severe BPSDs for each one of the BPSDs present here, with a significant increase seen in apathy, disinhibition, irritation, motor, appetite, psychoses, agitation, and anxiety. Next, we look to the combination of Braak stage greater than 4 and neocortical Lewy bodies. Here we see something very interesting, that in depression and anxiety, individuals that have both Braak stage greater than 4 and the presence of neocortical Lewy bodies, the levels of moderate and severe depression and anxiety are much higher than those that have neither pathology or those that have one or the other pathology, indicating that it is somehow the combination of these pathologies that are associated with an increased moderate and severe depression and anxiety. However, when we look at this in late, we do not see that there is a significant increase in moderate or severe BPSDs for those that we looked at in the association between Braak stage greater than 4 and late. However, there may be significant increases if we were to increase our sample size and thus our statistical power. So our main takeaways here is that in early cognitive impairment, Alzheimer's pathology or Braak stage greater than 4 causes increased or is associated with increased levels of psychosis, agitation, anxiety, apathy, disinhibition, irritation, motor issues, and appetite issues. And then when in the combination of Braak stage greater than 4 and neocortical Lewy bodies, there is an increase in depression and anxiety compared to neither pathological group or one or the other pathological group. So I want to say thank you so much to everyone listening and to my mentors at the University of Kentucky, Dr. Greg Jica, Dr. Aaron Abner, and Dr. Peter Nelson. Thank you.
This is Leili Soleimani from Mount Sinai ADRC, New York. The topic of my presentation is the speech biomarkers and depression dimensions. Speech and language impairments are known to be present in cognitive disorders as well as in depression and other neuropsychiatric symptoms. The objective of this study was to assess whether speech markers could be helpful to provide a more granular and objective measure for better characterization of depression dimensions. Why speech? Well, there's a clinical relevance, as we just mentioned, but also because it's easy to collect and it's objective, and it is easily quantifiable, allowing for complicated computational analysis. Speech can be collected through different tasks, including picture description that was utilized in the study. And the speech is processed to provide acoustic variables such as pitch and speech segments. It can then be transcribed to text to provide many linguistic features at the level of the lexical or words or the structure of the sentence. The study presenting today is part of a collaboration between Mount Sinai and University of Pennsylvania. The data is from the University of Pennsylvania and the Language Consortium. Neuropsychiatric symptoms such as depression, apathy, and anxiety are based on geriatric depression scale, and we also have an item on subjective memory complaints. We have previously published these factors in different populations, as mentioned here. Here are the list of some of the variables that were looked into in this analysis, including acoustic variables, pitch and pauses, and also some semantic and lexical variables, including the use of prepositions, length of the word, age of acquisition, which higher age suggests the more complicated words. These are the words that are acquired later in life. We also looked into emotional aspect of the speech, such as balance and arousal, which refer to positivity or negativity of the words based on the choice of the words when compared to the published norms. We examined the correlations between the speech markers and the depression dimensions while co-varying for age, sex education, and mental status exam. So the results here summarized. For 112 subjects, 40% female subjects are AD, MCI, and normal controls, with a minimum mental of 23.69. In brief, some of our main findings was in relationship to subjective memory complaint, which was associated with more pause in the speech, shorter words, also simpler words which are acquired younger in age, and using less prepositions. These are words such as in, on, beside, and less use of them suggests simpler sentences. In regard to the affective symptoms, patients reporting dysphoria, or what we generally consider as sad mood, also use simpler words with younger age of acquisition. Patients reporting more apathy or anhedonia actually use more words with negative content. Anxiety was associated with trend for longer pauses and simpler sentences with less prepositions. So some features similar to cognitive impairment. Obviously, there are many ways to look into these analyses of the speech corpus, and we're looking into other forms of analysis of this data. As a next step, with the funding from the Alzheimer's Association, we're now in the process of collecting speech from our ADRC participants, and we're going to include normal subjects, MCI, and mild AD, with the focus more on apathy domain. We have now collected about 95 samples, and with the valuable data from the UDS, and we're also collecting apathy scales for these subjects. In brief, our results from this pilot data should suggest that dimensions of geriatric depression scale, including apathy as subjective memory complaint, have distinct speech features, which have the potential for being used for not just the cognitive but also behavioral aspects of dementia, with the goal to improve objectivity and to develop predictive models of the disease and potentially a treatment response. Thank you very much for listening to my presentation.
My name is Amy Way, and I am an assistant professor in the Department of Neurology at UT Health San Antonio, and worked with senior faculty within South Texas ADRC on this project looking at disinhibition and cognitive decline. Recent work has indicated that not only are different symptoms of mild behavior impairment better at predicting cognitive decline among Hispanic and non-Hispanic white groups, but hazard ratios for incident cognitive impairment are broadly higher among Hispanic groups with mild behavior impairment relative to non-Hispanic white groups. Furthermore, another group, when exploring a relationship between apathy and cortical atrophy in European American and Hispanic American older adults, found a significant negative relationship between apathy and superior frontal volume in the European American group, but in the Hispanic American group, there was a relationship between rostral anterior cingulate volume and apathy. The authors went on to postulate that higher cortical reserve in the orbital frontal cortex may be related to more brain reserve and higher inhibitory control among the Hispanic groups because it would be needed for folks who are bilingual or interact with multiple cultures. Within this context, we aim to identify the endorsement of disinhibition among non-Hispanic white and Hispanic NAC participants, discussed disinhibition as a predictor of cognitive change within these groups, and calculate predictive power for different cognitive diagnoses. Our analyses included participants who identified as either Hispanic or non-Hispanic and white, completed more than one visit, and had a diagnosis of MCR or normal cognition at the time of their first visit. The groups are statistically different on each demographic characteristic. However, the groups are similarly highly educated and include more female participants relative to male participants. The report of disinhibition occurred at a higher percentage in the Hispanic group relative to the non-Hispanic group. However, the severity of disinhibition was not significantly different, with the majority of co-participants reporting a mild change. In looking at hazard ratios for developing dementia, report of disinhibition at the time of first visit was associated with about a 4-time greater risk for developing dementia after controlling for age, sex, and education. Multi-state models were used to identify relative transition intensity for those who reported disinhibition versus those who did not. In the Hispanic group, only change from normal control to MCI was significant for greater transition intensity, while hazard ratios were significant for each phase in the non-Hispanic white group. Within our sample, a number of participants did ultimately end up with a diagnosis of dementia. Not surprisingly, for both groups, amnestic dementia was the most common syndrome type, and only one participant in the Hispanic group was present for each behavioral variant FTD, PPA, and PCA. Next, we looked at hazard ratios for developing specific dementia syndromes in the non-Hispanic white group. Report of disinhibition was associated with a 4 times greater risk of developing amnestic dementia, primary progressive aphasia, and dementia with Lewy bodies. This similar risk is also demonstrated in the amnestic dementia in the Hispanic group. While we have not yet looked at the interaction of ethnicity in the pooled sample, the hazard ratio for developing non-amnestic dementia appears to be different between the Hispanic and non-Hispanic groups. It could be interesting to look at the potential for a relationship between cerebrovascular risk factors in this discrepancy. Our next step is to calculate ethnicity interactions to determine if disinhibition does predict decline and diagnoses differently between the groups. We also plan to include interactions with other markers of neurodegenerative disease, including imaging, biomarkers, and neuropsychological test data to help identify early profiles for early diagnosis and management. Thank you.